The transition from, I think there's a problem, to engaging in dealing with it is very stressful for you guys out there. And please know that we know that. Maybe we don't always express it on, day one, minute one, but we know that you're suffering. And we know that, and the best way to fix that suffering beyond getting you the baby you want is education and learning about what the process is like and what our shared expectations could be. In the last 5 years of my practice, I use that phrase all the time. Like, as long as we leave here today with shared expectations, we're going to do fine.
From our Building Your Family community, this is the Building Your Family podcast. I'm your host, Lisa Schumann, author, researcher, and reproductive medicine therapist. As the leading destination for support and education for people using reproductive medicine to grow their families, we cut through the noise to provide you with research-based information, effective and actionable strategies, and the support that you need to feel better so you can get into the driver's seat of your life and build the family of your dreams. We look forward to seeing you inside. Welcome back to this special episode of the Building Your Family podcast. So I'm going to pivot a little bit today because there have been so many people who have reached out to me with lots of questions about how our fertility industry is changing. What's really complicated, I think, for most patients to know is what's happening to our industry. I felt like it was really important to start to share some of the details of that. And we very often focus on the emotional and practical aspects of family building and what's going to be important for you to have the family of your dreams in the easiest way possible. And so to that end, I felt it was really important to bring on somebody who has a lot of know-how and also a big heart. So I'm going to introduce you now to Dr. Eric Widra. He is the Executive Senior Medical Officer and Vice President of Development for Shady Grove Fertility and US Fertility, which he'll explain to you in a little bit. Dr. Widra and I met a long time ago. And when we met, we discovered we have very similar tastes in music, but also a passion for this industry. And over the years, I've seen Dr. Widra really do so many wonderful things for people, both individually and for his organizations. He's reached into his own pocket and into his own calendar to offer his time for Resolve and all sorts of organizations, and has done so much for small clinics, but also for the industry. So I'm so excited to introduce you to Dr. Eric Widra. Thank you so much for coming.
Thank you for such a kind introduction.
It's my pleasure. So why don't we start a little bit with, I know a lot of fertility patients are a lot younger than us, and this is probably something that they're kind of accustomed to, but historically we know things have changed from being these small mom and pop shop sort of fertility clinics, maybe when you were practicing as a physician, to now being these large groups. And I think that sometimes patients, even if it's the first time they've encountered a fertility clinic, are kind of overwhelmed by the enormity of it all. What could we say to people to comfort them and help them understand that we're really still continuing to look out for their best interest?
It's a great way to start the conversation. And, one of the things that I reflect on a lot when I get asked this type of question is comparing and contrasting, sounds like an essay question, the similarities, the uniqueness of fertility, but also the similarities to other areas of medicine. The thing that jumps out at me the most is the fact that a lot of people, including yourself, refer to it as an industry. You don't hear the hematology-oncology industry very much.
That's
or
true.
The infectious disease industry very much, although in many ways, some of those specialties have gone through the same types of consolidation and development that we see in fertility and reproductive medicine. And I think part of that characterization, and I don't mean this anything personally, but part of that characterization grows from a real disrespect for infertility as a medical problem. You're not getting into a therapeutic area, you're getting into an industry. And again, while I know it's not intentional, and I'm not trying to be, to pick on you using that, mm-hmm. I think it is reflective of the way people in general look at infertility. And I think that has ramifications for patients when they get into this space and go through it. They feel like they're stuck between, buying a commodity, which is, fertility care, and the intense suffering that they have but the inability to build or grow their family. And I make a very sardonic joke. The problem our patients have is they're not sick, right? They have free time, but they don't feel bad, right? They don't have something that requires them to be hospitalized or given a specific prescription for. So they're entering this hybrid world of healthcare where, without fertility treatment, that their lives, their health would not change, but their life changes, right? Because they can't do what we all plan to do. Almost all this is we should start a family. So when I start to walk people through, how this has changed and how this has evolved over the years, I always like to kind of frame this and say, let's look at this the way we look at other areas of healthcare, because there are some important parallels and there's some important differences. And one of the biggest differences is that, any one fertility doc or, in a relationship, typically, not always, but typically has more than one patient. And if you start to get into it, it's really even more than two, right? Because you have someone who wants to be a mom or a dad, somebody commonly, but not always, wants to be the co-mom or dad. And then you have these embryos that you make, right? And at least if you do IVF. And the consequences of creating those embryos and the disposition of those embryos has all kinds of ramifications, right? And so those are the things that are super unique about the infertility healthcare environment. But many things are different. Are similar to the rest of healthcare. So I digressed a bit on that. Can you bring me back to the trunk of the tree about?
Yeah, I agree with you. And I think it's so hard for people to appreciate what you're saying because and I think for people who don't understand fertility issues, the parents, the friends of people who are infertile don't really appreciate the fact that it's not visible. You're not losing your hair from cancer treatment. You're not going through a medical procedure where you're going to have to be in bed for a month later. So people don't really appreciate the gravity of the process and how desperately people want to build their families. And I think in the same breath, it is a little bit different because people who go through cancer treatment do have this built-in, almost sympathetic support system where we don't have a fertility treatment. And so I think people are even more ashamed of wanting to have that connection from their doctor. They don't feel as public about it. It's more scary for them to go to their gynecologist and ask for a referral. And so I hear what you're saying, that it's so important to appreciate that every industry has expanded, even the industries that are really highly sensitive. And yet I think that patients who are going through it, because they're so sensitive, feel a little bit frightened about the fact of kind of diving into these large groups where they're thinking, well, I hope that my doctor is going to understand me. I hope my doctor is not looking at his watch and saying, when's my next patient coming? I hope someone's going to get back to me at the end of the day and I'm not in this huge system. And so it's tough, right? I mean, I think, Disney is probably the best example of a large group that's been able to make everybody feel special, right? And so I guess the challenge here is in the fertility journey, how do patients find a way to make sure that they still feel special when they're in this large group?
Yeah, and in some ways, I think this has gotten, if there are ways it's gotten more challenging, ways it's gotten less challenging. So I draw a lot of parallels to oncology when I talk about fertility treatment, because if you look at how that industry has changed, I used industry intentionally, over the years, there are a lot of parallels to what we do. And there are also parallels in terms of the emotional impact of what people go through. And in fact, the emotional impact of an infertility diagnosis, when measured, systematically, is comparable to a cancer diagnosis.
Yes.
And people really do feel like their lives will never be the same if they don't have children. Those are real things. Oncology used to be, this, you didn't talk about it. There wasn't that support system,
True.
that you very aptly described. And you went to a person and you hoped you connected with them. And then, you got some form of treatment. But what you saw happen over the last few decades is that as we got better at doing cancer treatment, there's consolidation. And so there are cancer treatments and cancer networks. And pretty soon, even all the research into cancer is done not just in the universities anymore, but also out in these private, cancer treatment centers. And all that has been good for patients getting treated for cancer in terms of the outcome, which is more people surviving. If you replace cancer with infertility therapy and everything I just said, it would be accurate. Problem is, you can still find a crappy oncologist, and you can still find a reproductive endocrinologist with whom you don't feel comfortable, or who doesn't meet your needs, or who doesn't want to meet you where you are. And so, how do you navigate that? Again, a long answer to a question. So, the answer is, in my opinion, beware of online rating. This is the bane of physicians' existence these days.
Yes.
You're completely at the mercy of, one person who has a bad day. Even if you're a terrible person, if you're a terrible doctor, you're still at the mercy of that one person, right? So there's just no checks and balances there. But do some homework. I'm a data guy, and the first thing I would look at as a patient is I'd go to places like SART, CDC is getting shut down, and say, hey, here are the three clinics in my neighborhood. Is there an outlier here in somebody having really poor success rates? Because at the end of the day, you want to have a baby, right? I mean, the relationship matters, but you want to have your baby. And so if somebody's really poor, I would, take them out of the running. And it's okay to meet a couple of doctors.
Yes.
But my strong advice is also don't dismiss a really good interaction if it's your first one. If you sit down with somebody, and I'm going to say that in both directions, if you sit down with somebody and you really feel connected and you feel like they talk to you, that's okay. And similarly, if you felt no connection, but everybody goes there, you don't have to say. The other thing that I've tried to do over the years is, and not every doctor does this, and I don't mean this as a criticism, it's just style, is set expectations for how I'm going to interact with the patient or the couple or the family. But you can do the same thing. You can say, hey, what can I expect?
Yes. It's great advice.
In terms of am I just going to talk to your nurse, or am I going to talk to you? Do you do email? Do you do portal? And again, these things are tricky issues for all the providers, whether they're nurses or advanced practice providers or docs, is that, all of these methods of communication change expectations how they evolve, right? So, if your doc responds to your first portal message within 5 minutes, that's your expectation going forward. And then your doc goes on vacation or to his kid's graduation, and you don't hear from him for a week, you got to be really cautious with that stuff. So, asking, hey, what are my expectations here? Who do I talk to? Who communicates, instructions to me? And there's no one right answer there. For me, this is mechanical.
Yes.
You let me know what to do, when to do it. I don't care who tells me, if something goes wrong, you can call me. And then I have others who are like, no, I'm halfway through I was at another clinic and I was halfway through my IVF stimulation. I just felt lost. And, that's a problem for us, right? Because if you take care of everyone like the person who's lost, even if they don't need it, you don't have any time for anything else.
Yes.
But if you just treat everybody like it's a mechanical thing, then you don't really meet those people who need more connection where they are. And so it's okay to ask and to say, hey, what about this or that? A doctor who's going to find good fits with their patients is somebody who's going to be honest about that. So if somebody asked me personally when I was clinically practicing and very active, will you do portal with me? I'll say no, because I don't have time to look at every portal message, and I need somebody to triage that for me, and that's the nurses. Now, if the portal message is I need to talk to Eric, then we schedule a phone call or call you.
Yes, that's great.
So again, I'm sorry, Lisa, really long answers. But
no, it's a great answer.
Issues for people trying to navigate this.
Yeah, it's very helpful. And I think it's important that patients realize that self-advocacy is so important, and people feel intimidated and worried, but it's so important to self-advocate. But also, I think that it's really helpful what you're saying, because it points to something else that I wanted to ask you, which is that I feel like we're in a tough time right now. And I think that you can speak to this because you were so involved with SART directly. And I think that that's so wonderful that you've volunteered your time to do that, and so valuable for us. Yeah, I really appreciate it. And I think that people really need to weigh the importance of the doctor and the lab with social media followers, with reviews, with all the stuff they see online, because patients are so driven by how many followers somebody has rather than what sort of success rate. And in the end, yes, you want to be entertained or happy with your doctor, but you want a baby. So can you explain that to our audience a little bit? Because I think not everyone is clear about that.
It is a really tough topic, right? Because this is how we go through our world, right? Hey, who cuts your grass? How is dinner at this place? You
Yes.
know, and those outcomes are pretty easy to measure, right? I liked my dinner, the service was good, the grass was cut, but as you get into healthcare, and I mean this broadly, those
Yes.
outcomes are very different. And there's an enormous effect of the relationship between the patient and the provider and the treatment in healthcare that doesn't exist anywhere else. I have good friends who are in primary care, and it's like, well, if you're disappointed that your blood pressure is not down, you could consider taking the medication we prescribed.
Hmm. Yes.
And that's that. And I mean that tongue in cheek, but that's a real thing that happens in healthcare every single day.
Hmm.
And so there's that relationship that's there, right? And so physicians, because we're people too, we want to be liked, we really do. And
Hmm.
will sometimes do stuff because they feel like they need to be liked, and that can lead to bad decisions. So our industry, like cancer industry, is littered with technologies or treatments or ideas that were going to be the next cool thing that changes stuff, and didn't do anything when you really measured it, and in some cases was harmful. I can't tell you how many social media things I've seen over the years where it's like, Dr. X was so great. He tried this new thing for me because he thought it would, that would really help me.
Yes.
And then the likes pile on, right? It's like, yeah, he really cared about you. He wanted to do this one thing. Turns out it's nonsense.
Yes.
Now, he may
Yes.
believe it does something,
100%.
but when you actually measure it, it doesn't. And so that's where this whole, ranking and rating thing gets so difficult. If we have time at the end of this portion, I'll
Yes.
tell you a terrible story that happened to me. More terrible for the patient than for me. I recovered.
Really? Oh, well, tell us the story.
But anyway, I think you need to be really cautious about that and really value your own evaluation of the relationship that you're starting. Go see the place, kick the tires of the facility, ask questions, but be respectful is my advice about how deep you want to go. Are your expectations okay? Because
Hmm.
sometimes we have to change our expectations in healthcare
Hmm.
as patients as well as providers. So the woman comes to see me, and I sit down with her, and I haven't done significant amount of surgery for a long time. Like many IVF docs, I started out as a surgeon, and it just went down over time. But she wanted me to do an operation called laparoscopy because she had something inside of her. Asking her about this, she thought she had she was literally psychotic. She was mentally ill. And I felt so bad for her. I mean, she really thought there was something living inside of her that needed to be removed. And I was like, oh my God, I don't know how to address this. And I pulled all my, therapeutic mental health training out of that I could and did the best. And I called the doc who was in there. I said, he's like, I'm really sorry, but I didn't know what else to do. I was hoping you would be able to at least talk to her. Well, it turned out she had a really serious mental illness, but she's also pretty good at a computer. And I got yelped to death.
Wow.
Yeah. It was when I realized you survive it. And again, this is more about providers and patients right now, but you asked me to tell a story.
Hmm.
I told my nurses what happened. And what they did is they reached out to some of my fans who were patients or ex patients and asked them to help. And pretty soon the positive reviews drove the negative review down. But it felt so bad, right? Because you couldn't help the person. But at the same time, you felt hurt by the person.
Right. So it goes both ways, right? The
Yeah.
patients feel sad, but also the physicians can be really upset about.
Yeah, I mean, there are people in every area of life that are too mechanical or burnt out or who've lost their sense of empathy for the situation. But those are the exception. That's not most. Everybody I know wants to do the best they can to help their patients build their families.
Yes. So if a patient's starting in their journey and they say, okay, I've got to find a provider, do you recommend that they first take a look at SART or first take a look at the doctors on their plan or that who their gynecologist is recommending? How would you recommend a patient start that process within the framework of what we have now?
Yeah. So what I would suggest is, and again, people have varying degrees of comfort with discussing their own medical problems with their peers, right? But you shouldn't with your doctor. So I would start with, hey, who's in my plan, right? Because if you have a benefit for infertility, which we should talk about is improving for folks.
Yes.
If you have a benefit for infertility, you want to use that benefit. And then I would, call your gynecologist and say, hey, this group is in my network.
Hmm.
What do you think? And if the answer is, I think they're great, then is there somebody in that network you strongly recommend? And if there's more than one group in your network, yeah, you may want to look at, that's where I said, look at the success rate. So if you're unfortunately uninsured for this or underinsured for it, you can look at who's in your community and then whittle it down by success rates and then ask somebody you trust about it. Now, a lot of OBGYNs have longstanding relationships with, just because we have similar training. We all do an OBGYN residency. We know each other. A lot of people stay in the community where they train. So, personal referrals are good, but they're not perfect. I don't recommend doing any one thing to kind of choose the doctor. The thing that I'm going to say that I might get in trouble for later is the doctor you see isn't as important as it used to be. And that's the oncology analogy, right? It's important for your relationship and how you feel going through the treatment, but it's not very important for the outcome anymore.
Yes. Imagine your beautiful future. You're snuggling with your child. You feel so connected to them. Your friends and family are so happy, and you have everything that you've ever wanted. I want this for you too, but I want more than that. I want you to feel secure knowing that you've made the best decisions, not just short-term, but long-term for your future family. Wherever you are on your journey, whether you're choosing a donor, choosing a clinic, learning how to talk to your donor-conceived child about their origins, all of these decisions will have wider implications for your future. And I want you to have the right resources so you can feel empowered and confident at this very important time in your life. That's why I'm so excited to introduce you to Building Your Family. It's the only expert-guided platform designed for parents and parents-to-be using reproductive medicine. We provide unique strategies that you won't find anywhere else to make your path to parenthood smoother and more informed. And that's why our approach is about offering practical and actionable steps that you can use right now. Whether you're just starting out or already deep into your process, Building Your Family is here to guide you with expert advice, specialized education, stress reduction strategies, and a community to support you every step of the way. We can't wait to see you inside. So that's a great segue into this next question, which I've explained a few times on this podcast, but maybe because you're such an expert, Dr. Widra, you can explain to our audience what SART is and the importance of having a good lab.
So SART is the Society for Assisted Reproductive Technology, and it's a society within the American Society for Reproductive Medicine, which is every medical profession, every specialty has a, governing is the wrong word, but an organizing society. And then there are subsets of that depending on what you're interested in. So if it's oncology, well, then there's leukemia people, and then there's, GI people. So ASRM has assisted reproductive technologies. So we are the only medical specialty where there is a legal requirement for us to publish our success rates. And there are rules around how we publish them. So when this first started out, the CDC was tasked with this. But what the doctors did in concert with the CDC was develop our own reporting method. Now, it was meant to be cross-checkable. So the CDC numbers were the same as the SART numbers, and my clinic sends the same numbers to the CDC as they do to SART. But the reason we did that is we wanted to start having self-review, self-policing rather than external policing, because that's what actually works best and prevents us from getting more laws that don't actually have the intended effect.
Yes.
So in the old days, in the Wild West, when everybody was competing on success rates, there were people who cheated on their stuff and tried to massage the numbers. And once again, success rates have gotten so good over the years at so many places that it's not as big a discriminator as it used to be. But what SART does is that it collects the data on ART, or reproductive technology, which is primarily IVF, and publishes it in a free, publicly available website where you can look at your clinic's success rates. And at SART, over the years, they've gone back and forth with the degree of detail and complexity that they present versus not. But you can get some big picture stuff right there. Like if Clinic A in a 35 to 39-year-old puts back one embryo, which they should, and they have a 40% chance of delivery, and Clinic B does the same thing and has a 20% chance of delivery.
There you go.
That's important.
Yes.
Right? If one's 38.7 and the other is 41.2, that's not important. And some of those distinctions still actually exist out there. So the CDC has been defunded for their reproductive health monitoring, but SART will continue to do this. I don't know how they're going to get around the law, but we're not we're staying away from that. We think that this is it was an incredibly painful and onerous thing to do for many years. It's mostly automated now. And we think it's a good thing for transparency for patients to know what the probability of a pregnancy is. The reality is the differences are much less than they used to be.
Yes. And it's great for patients. And I hope everybody out there is listening to this because this is so important.
SART.org.
Yes. So important. So important. When a patient's looking at the SART data, they can see the difference between, maybe they talk to their gynecologist and the gynecologist says, yes, this group might be good, but try this one. And then they can actually compare the SART data between these different groups. What about the importance of the lab? Because we were talking about effectiveness of fertility clinics.
Thanks. Yes, I didn't touch on that. So there are three things that drive the chance of a successful fertility treatment. The number one is the patient. How old are you? What's going on with your eggs, and to a less degree, your sperm? Are there any other, big picture problems like issues with the uterus? The second is the physician component. How do we approach the medicine of stimulating your ovaries and trying to get your eggs in the lab for IVF? And then probably the most important part is what goes on in the laboratory. And this is in some way an undertold story. The ability to have, the probability of a birth from one IVF cycle that's probably similar to, 6 months of trying on your own. It's pretty remarkable. Now, you don't do it if you don't need it, but, we've come a long way in terms of our ability to optimize the conditions for eggs and embryos to grow in the laboratory. Similarly, egg freezing, which is a relatively new technology, took decades to develop because it's such a fussy technology and so difficult to do. Those are some of the issues with the lab. The thing that you can try to interpret by going through the data, other than the raw pregnancy rates, include how many embryos go back in the uterus in an IVF cycle and how many multiple pregnancies exist. So what you want to find, and this is totally back of the napkin out there, is the clinic that has the highest number of pregnancies with the fewest number of embryos going in. And then consequently, they'll have the lowest number of multiples. And we argue vehemently about ways to identify which embryo we need to do that we need to use to accomplish that. That's one way of thinking about it.
That's great. And what about the new technologies? Do you feel that having these networks will enable more groups to have these new technologies that are starting to automate the lab, for example, or some of the new procedures that we're kind of looking at to kind of rejuvenate eggs and all these new advances potentially?
This is where the commodification of this is really problematic, and where we didn't start out the consolidation in the same way that we did for oncology. The desire to find something else to do, something new, something that's going to make outcomes better is ever present. But the methods we need to use to test that, to figure out whether something is good or not, is really difficult. My bias will absolutely show in this answer. At USF and especially at SGF, we have supported through real money that doesn't go into anybody's pocket, research to try and understand which things work and which things don't. And it's been one of the proudest experiences of my career at some of the things that we've been able to publish over the years. Unfortunately, usually showing that something we hoped would work doesn't, but occasionally finding things that are beneficial. And so those are really important. And so the problem that we have with consolidation and networks being run in a for-profit environment is it's much easier to bring something new in and charge for it than it is to test it.
Yes.
Before you do. Because the first is, and again, I don't mean this in a unnecessarily mean-spirited way, but the first one is just simple, right? It's like, I could try this. It probably doesn't hurt. It makes money. And if it helps, great. To figure out if it works or not, you got to first invest in the research to do it, and then stand up and say, hey, it did or it didn't work. But there have been some really bad outcomes in terms of people trying too many things at once that cause real harm to patients. And I think that's a big challenge.
Yes, absolutely. I'm so glad you raised that, because one of the things that I think patients struggle with so often is, as you had said earlier, they may feel really relieved that their doctor is trying 50 different things because they feel like my doctor cares about me. But maybe that patient just needs more times up at bat, right?
Yeah.
But the patient doesn't feel like the doctor who does that really cares as much. And so I think what you're saying is, if you have a good physician and you know the lab is good and you know the SART report is showing evidence of that, then you can have more confidence if your doctor says you need more times up at bat. And you don't need to really rely on all these new technologies and treatments and rejuvenating your eggs and all these sorts of things that people really want because they're desperate, right? But it may not be the answer. If they had just gotten back up to bat more, they may have gotten pregnant.
Yeah. I mean, the fountain of youth is one of the oldest myths in humanity, right? That we
Mm-hmm.
can do something to go back, right? And
Yes.
you can't. I think that when I've been successful in situations, it's been because I've been able to articulate to patients that why I think it's not working without resorting to desperation or
Yes.
getting into just trying anything that's out there. And it's hard. There's a lot of pain across the table when you've got that negative pregnancy test.
Yes.
And to get people from that place of panic and pain, and it is a panic place,
Yes.
to understanding the science of why is hard work for both parties, right? I
Yes.
want you to feel sorry for us; it's our jobs, but it's hard work emotionally for somebody to say, I gotta accept this, and I have to figure out what's next for me. And sometimes what's next is a very unpalatable choice. Sometimes it's just another turn at the plate, like, as you suggested.
Mm-hmm.
And
Right.
and so yeah, explaining that and explaining statistics, which is complex to begin with, to somebody who's
Overwhelmed.
I've had yeah, very very educated people say to me, like, if it's a 30% chance, then I'm done after 3 cycles. But no, it
Yeah.
doesn't add up.
No,
It's
it
30%
doesn't
each
work.
time.
Right.
You know?
It's a roulette wheel, right? It's not
Yeah,
building blocks.
yeah.
It's so true. It's so true. And it's so hard, right? Because you want it to work. And so that's why I think that sadly there's so many of these people on social media who will sell snake oil or say eat 5 pineapples or do whatever, and that you'll get pregnant that way. And patients sadly fall prey to those people.
Well, and the harder problem is somebody maybe 5 pineapples does work, but you have to test it.
Yes.
Which means you
Right.
give 1,000 people 5 pineapples a day, and 1,000 people no pineapples a day, and you wait a year and find out what happened. Good thing is pineapples are cheap. Try to do that with a medication.
But you also don't want to lose precious time while your eggs are getting older, right? And that
Yeah,
happens. Sadly, patients, I think, just continue to try these unconventional things for so long. And then sometimes it's too late. And so, my goal is to really try to help patients avoid that.
there's nobody who doesn't want the next great thing to work. Problem is, it's got to work.
Right. It's got to work. It's got to work. Yes. And what do you think about what's happening? I know you're practicing in this world in a very tough time in our country where we're probably going to see a lot of our liberties roll back and more restrictions put in place. And at the same time, since 2015, when gay marriage became federalized, we were now in a situation where we feel very comfortable with a very mixed practice. Most people, right? They see single patients and trans patients and same sex patients. And so now a big portion of the fertility market is potentially going to be more restricted. And so, being part of a large group, how do you manage that?
The answer is I don't know yet. Is the honest answer, but it is something that's on all of our minds. The other, happy news of the last decade is that we've gotten more people coverage for fertility care.
Yes.
Doesn't benefit me at all. I would put in a pitch for Resolve, which is the nonprofit that helps improve access to care. I've been on the board for many years for family building of any kind, including adoption. I would be surprised if coverage gets rolled back, but continued expansion is certainly at risk. Now, President Trump has said that he wants to be the fertilization president, whatever that means. But if you read his executive order, it's really an order to check it out and see what we might be able to do, which is a great start. Don't get me wrong, but it's far from mandating coverage. So I was being a bit digressive. And then we get into to groups that are traditionally marginalized because they're uninsured or underinsured or carry some social label that somebody doesn't like. I think that could be a real challenge going forward, especially for the LGBTQ community. There is such incomprehensible animus against that in some quarters in this country that
yes,
I think that it's such a small population that they're easy to identify and exclude, and so I absolutely worry about that. As a clinic, we are completely, as a network, we take care of people who want to build their family.
right.
We don't
Period.
care how you come in. There's some really interesting science and questions about helping some people who are trans, getting eggs from somebody who's been on testosterone for 10 years, things like that. I mean, those kinds are intellectually stimulating for us.
Mm-hmm.
But on the social side of that, yeah, we're completely like whatever, and we will continue to. There's nothing that would change our approach to that. The way that these levers are pulled are through insurance legislation. So even though the insurers might not care, employers can care, the government can care, the federal government can care, and so time will tell. It's a very sad thing to contemplate, and my hope is that it becomes too much work for too little benefit for the people who are opposed to it.
Yes. And what about the patients who say, well, should I start moving my embryos to different states? Should I start thinking about maybe doing things like a second parent adoption now? Maybe I should create embryos right away before there's more restrictions. What would you say to those patients who are sharing those concerns?
When the Dobbs decision came out, my answer to that was, let's stay tuned and be careful, but I don't think we need to panic yet. And then there were cases, I believe, in Louisiana where patients couldn't move their embryos, were required to use them. I don't remember the exact details. So yeah, it may become important as to where you live and where your embryos are. And I think that most of the big networks are doing things to make sure that we have some coverage there. So some networks are, and again, I want to be careful of the details here because I don't want to get it wrong. But for instance, we have practices that keep frozen material on site. We have practices in our network that send them to a centralized facility. But what USF has done as a network is make sure we've got facilities that are spread around the country, and that are typically in states where state legislation is very unlikely to alter practice patterns and the status of embryos. But you can never say never. What I don't think people should travel to get care unless they're in an environment where there are already significant restrictions in place, like you can't move your embryos or you can't discard them. In those cases, I would tell you to travel for care. If you're in an environment where the status of frozen embryos is not well established, you may want to move them to a place where it's widely considered to be safe. And that's not something I said after the Dobbs decision.
Yes, because things are scary, right? And we don't know which way the tide's going to turn. I mean, hopefully it will stop, but there are no signs of that at this moment of the problem stopping. And so,
yeah, there's been so much norm breaking in terms of the relationship between federal government and state governments that we really don't know. But what we try to do is do the best job for the couple that's sitting, or patient who's sitting in front of us, and help them to get to what they want in their family, and keep our eyes peeled as to what external forces may influence that.
So do you think that people should talk to their doctors as they start their fertility treatment about kind of, where do I put, if I'm, creating 6 embryos or, however many, maybe I'm in a same-sex couple and I'm going to go first and my partner's going to have a child with their genetics later. Should we talk to our doctor about maybe moving embryos so that we can think about that?
It's such an interesting question and hard to answer, because you and I today are speaking a shared language, right?
Mm-hmm.
There's a lot of people who don't know what an embryo is when they come into the office. And so this concept of, coming in and learning that you may actually be creating embryos in a laboratory, there are many people who are still miles away from understanding what the disposition of those embryos is. They're just reckoning with, holy crap, if I want to have a kid, I got to do this.
Mm-hmm.
And we're like, yeah, we're used to it. It's like we do this all day, every
Right.
day. This is great technology. Go sign up for this. And it is all those things. But to somebody who's naive to it, it's huge. And so what we try to do is, and again, I don't want to be practiced too, but we try to make continuing education of what's going on a big part of what we do. So we do video modules and written materials and things like that, so that as patients are working their way into treatment, they're getting lots of different ways to learn about stuff.
Yes.
Some might be going to, Building Your Family on YouTube.
Mm-hmm.
Others,
Yes, absolutely.
there's lots of ways to access it. And so as they get more informed, yeah, but the rubber meets the road someplace. You got to sign a consent form that says I'm going to freeze my embryos or I'm not, and I want them to be here or there. So that's the time to have those conversations. And honestly, sometimes they're simple. You don't necessarily have to talk to the doctor about it. Like your nurse coordinator may have all the answers for you.
Mm-hmm.
It's like,
Mm-hmm.
oh yeah, don't worry. We're in a state, we have them here, and your consent form says if this happens, we'll do this. I'm not saying it's always that way, but the way we're talking about it, I mean, even listening to my own words, it sounds scary. It's not scary everywhere. And if you're at a place that's thinking about these things, they'll probably talk to you about it up front.
That's great. So I think ultimately what we're saying is, find the right practice, find the right network. Don't be worried about the network as a group, because they might have access to a lot more technology, good lab information, good systems, and that ultimately to be able to share with your doctor what your real concerns are.
Yeah, look, if you look at healthcare in general and you look at outcomes, whether it's open heart surgery, asthma, knee replacements, hip replacements, really crazy things like transplants. Like the more people do, the better they get at it.
Yes.
Because you see what a small group might see in a month, in a week. And you learn from that. And, I always joke, there isn't anything we haven't seen until next week. Something will come up. I'll be like, I can't believe that happened.
Yes.
Most of these things are not consequential or dangerous, but you're like, go figure. So my only caveat of that was, you want to be if it's part of a larger group, you want to see that they're kind of engaged in the science of the community. I think that's important.
Yes, 100%.
I don't want somebody who's doing his first knee replacement on me.
Yes.
Now, if he's got a mentor who's done 10,000, I'm okay with that.
Yes.
So I don't want you to. I don't want to scare you away from our younger doctors. They're impeccably trained and they have great mentorship. And you may find out that's a better fit for you. Not everybody wants a guy with gray hair and wrinkles.
Well, but I think, exactly to your point, Dr. Widra, which I talk about every day on this podcast. And I think it's so important that people really need to think about expertise and the science. And of course, you want someone with a big heart, but all of those other elements, having the science, having the research behind you, having a seasoned person is hands down more important than the likes or the followers or any of those things that people very often will be attracted to. And so it's so important to get the right information if you want to build the family of your dreams in the easiest way possible.
And the scariest thing about the likes is that, doctors are under pressure, and this is not just reproductive medicine, they're under pressure to improve those. And that's a hard thing in
Yes.
healthcare. Every mom who brings a kid with an earache and sort of hopes they can get antibiotics and fix it.
Yes.
But if the kid doesn't need antibiotics and you give it to them, there can be harm, but maybe a thumbs down.
Right. And you want your doctors to be spending time doing research or being involved in professional associations rather than making TikToks.
It's a real challenge. And that's why all of us hate it so much. It's not that we don't want to make people happy. It's that we don't want to give up our autonomy in terms of what makes sense and what we think is good for somebody in order to get a like.
Yes, 100%. 100%. So I think that's a good place for us to wind down, because I think that that's such valuable information. I hope that everybody's listening to that. And I really appreciate you being here. You're so wise and you've got so much to share. Where can people find you, Dr. Widra?
So I don't practice clinical medicine anymore.
Okay.
I am still very much involved with setting a philosophy and a tone throughout our network, and our network is nationwide, of adherence to research, to taking care of the person in front of you, to doing what's best based on the evidence, and trying to have that big heart. And it's hard some days, but again, one of the things I'm most proud of as I travel around the US visiting our practices is how much everybody really wants to help and is trying to navigate a landscape for both of us, for both the patients and the providers, that's always changing a little bit.
Yes.
It's always shifting. Sometimes it's dramatic, sometimes it's more gradual. yeah, I mean, that's why I still do what I do, is that I love the ability to go out and help others, help patients.
It's wonderful. It's wonderful. And people can also find a lot of your work in Resolve because you've been on the board for a long time. And so everyone can connect with Resolve because that's a great source of information too.
And we also have tons of content on our own website at Chief Fertility, as most practices do. So don't feel like if you're already with practice A, you can't go to their website and get the same good content. We're all trying to provide that. But the transition from I think there's a problem to engaging in dealing with it is very stressful for you guys out there. And please know that we know that. Maybe we don't always express it on day one, minute one, but we know that you're suffering, and we know that, and the best way to fix that suffering beyond getting you the baby you want is education and learning about what the process is like and what our shared expectations could be. In the last 5 years of my practice, I use that phrase all the time. Like, as long as we leave here today with shared expectations, we're going to do fine.
That's wonderful. Well, thank you so much for that. And thank you so much for coming. Really appreciate it.
Thanks for inviting me. Always a pleasure to talk with you. And I'd be anxious to hear any feedback you have from me down the road.
Okay. Well, we will certainly do that. And everyone out there, please share your information, your questions, and we will certainly tune in to YouTube and anywhere you get your audio platforms, because that will be a great place to communicate with us and make sure that you reach out to Dr. Widra there. And certainly come back, because if you come back, then we can keep providing you with information that will make your journey easier. And we really look forward to seeing you next week. Hi, it's Lisa Schumann. I hope that you enjoyed that video, and I hope it helped you. And if it did, please give us a thumbs up and subscribe, because that's how we keep going. It's really important to us. And if you liked it, you might like this one.